we're going to talk about IV and TPN therapy. So let's get started. Unlocking the benefits, a comprehensive guide to intravenous fluid therapy and total parenteral nutrition. The administration of fluids through the veins stands as the predominant method for delivering water, electrolytes, nutrients, and certain drugs when oral intake is either not feasible or requires supplementation. Intravenous therapy is given to restore fluid deficit or electrolyte imbalances, and it is also used to restore acid-base equilibrium. Emergencies necessitate the administration of medications in an intravenous solution. Total parenteral nutrition, TPN, becomes essential for providing nutrients to patients with gastrointestinal issues who are unable to get nutrients through other means. Decoding IV fluid concentrations. Understanding isotonic, hypotonic, and hypertonic solutions for optimal cell interaction. Isotonic, a solution with the same osmotic pressure as intracellular fluid, allowing body cells to be bathed without a net flow of water across the cell membrane. Hypotonic, describing a solution with lower osmotic pressure, less concentrated than body fluids, causing cells immersed in it to swell as water moves from the less concentrated solution across the cell membrane into the cell. Hypertonic, referring to a solution with a higher osmotic pressure than body fluids, letting cells in the solution to shrink as water moves out of the cell into the surrounding fluid. An example of an isotonic solution is 0.9% normal saline, while hypotonic solution is D5W. Blood transfusion breakdown. Understanding packed red blood cells, plasma, and plasma expanders for effective patient care. Packed red blood cells represent a commonly used product obtained by removing plasma, leaving only the red blood cells and plasma separately. Whole blood may also be administered to replenish blood lost due to bleeding. Packed cells find application in treating patients with anemia or other blood disorders, as well as in cases where a large fluid volume is not well tolerated, such as with renal disease or heart failure. Plasma is administered to boost blood volume in conditions like shock, provide essential proteins, and address coagulation disorders. In the management of shock, plasma expanders serve to increase plasma volume. Examples of these expanders include low molecular weight dextran, albumin, hespin, and plasminate. Nursing excellence. Key responsibilities in safely administering intravenous fluids for optimal patient care. The safe and effective administration of IV fluids is a collective responsibility shared by every member of the nursing staff. Nursing care for a patient undergoing IV infusion revolves around 4 key goals. 1. Preventing infection. 2. Minimizing potential harm to veins and surrounding tissues. 3. Ensuring the accurate administration of prescribed fluids at the designated time and at a safe flow rate. And 4. Closely monitoring the patient's response to both the fluids and medications being delivered. Safeguarding patient well-being. Strict protocols in ensuring sterility and safety in IV therapy equipment and fluids. All equipment and fluids utilized in therapy must adhere to strict standards of sterility and safety. Before adding any plastic bag or bottle of solution to an IV set, a thorough check for leaks and potential contamination is mandatory. When introducing a new bottle of fluid or additional medication to an ongoing IV infusion, practitioners must observe stringent surgical asepsis to prevent the introduction of bacteria into the patient's bloodstream. Due to the risk of incompatibility, it is crucial to verify the compatibility of each drug in solution. Pharmacists are valuable resources for consultation in this regard. Hand hygiene is essential, and hands should be washed immediately before handling IV fluids and equipment. When attaching the administration set of a piggyback medication to the port on the IV tubing, it is imperative to meticulously wipe the port with a fresh alcohol swab, scrubbing thoroughly to ensure proper hygiene before attaching the tubing to the container. Mastering fluid administration. Best practices for ensuring safety and security in IV therapy. For the secure administration of fluids, a clear airtight dressing must cover the IV insertion site, with the edges adhering to the skin on all sides. Tubing should be secured to prevent accidental pulling that may affect the IV cannula. Dressings are typically changed at least every 72 hours following agency protocol, and should be replaced if loose, soiled, or contaminated. It's crucial to label tubing and dressing with a date. Close monitoring of the venipuncture site is essential for signs of inflammation, with redness, swelling, and heat warranting immediate reporting, as they may indicate phlebitis. Chills and an elevated body temperature could signal a bacterial infection. Seamless transition. Best practices for discontinuing IV fluid therapy with precision and care. Upon discontinuation of an IV infusion, the tubing is clamped, tape is removed, and the needle or catheter is swiftly withdrawn using standard precautions. Ensuring complete removal of the catheter with an intact tip is essential. Applying a dry, sterile gauze with adequate pressure to control blood leakage and prevent hematoma formation is necessary. Raising the patient's limb, if possible, for a brief period helps drain blood from the insertion site and prevents blood leakage from the punctured vein. Ensuring patient safety. Strategic patient identification and central line care protocols for exceptional health care. The Joint Commission's safety goal mandates the use of at least 2 patient identifiers excluding room number when administering IV fluids. Verification of the patient's armband with the medication administration record and confirmation from the patient themselves are essential steps. Central line care, whether with gauze or transparent dressings, follows agency protocols, with examination and potential dressing changes at regular intervals. Best practice guidelines emphasize sterile procedures for central line dressing change and site care. The Central Line Bundle by the Institute for Healthcare Improvement, IHI, includes optimal site selection, chlorhexidine scan antisepsis, hand hygiene, maximal barrier precautions, and daily line necessity review with prompt removal if unnecessary. Optimizing patient care. Strategic approaches to blood drawing, total parenteral nutrition, TPN, and central line catheter types for enhanced treatment. Drawing blood from a central line is discouraged unless venipuncture is not feasible, requiring strict aseptic technique if performed. Needleless connectors and vacuum tubes are preferred over a needle and syringe. For patients with fluid and electrolyte imbalances, partial parenteral nutrition, PPN, is given when oral intake is insufficient, administered through a large peripheral vein. Total parenteral nutrition, TPN, is initiated if oral intake, PPN, or enteral feedings cannot provide sufficient nutrition. TPN solution, containing nitrogen, protein, source, hypertonic dextrose, vitamins, minerals, and sometimes lipids, must be infused through a central vein. Commonly used central line catheters such as Hickman, Broviac, and Grashong allow for long-term therapy and are administered with a pump or infusion controller device to maintain a constant flow rate. Mastering TPN catheter care. A comprehensive guide to safeguarding against complications and ensuring optimal patient outcomes. Strict asepsis is essential when handling TPN solutions and catheters due to the potential for bacterial growth in the solution. Although TPN solutions are prepared in sterile conditions in the pharmacy, infections remain a significant complication. Complications of TPN include glucose intolerance, electrolyte imbalance, phlebitis, allergic reactions, and fluid overload. The port used for TPN should not be utilized for any other solution. Initiate TPN with a slow flow rate, around 60 to 80 ml/hr, gradually increasing by 25 ml/hr increments until reaching the maintenance rate. Close monitoring of the patient during TPN is crucial, with frequent blood glucose determinations in the stabilization period. Insulin may be added to the TPN solution if the patient experiences difficulty with glucose tolerance. When concluding therapy, taper down the flow rate for 1 to 2 hours to allow the body to adjust. Precision in patient care. Understanding PPN for short-term IV nutritional support without central venous access. PPN is suitable for patients without central venous access or requiring IV nutritional support for a limited period, 7 to 10 days. Lower concentration solutions are administered to these patients due to the absence of a large blood flow, preventing dilution. Optimizing patient wellness. Strategies for restoring fluid balance and achieving expected outcomes in collaboration with providers. The primary goal is to restore the patient's fluid, electrolyte, or acid-base balance, with defined expected outcomes. These outcomes may include normal skin turgor, stabilized weight, balanced intake and output, normal blood gases, clear breath sounds, no evidence of edema, electrolyte values within normal limits, and the absence of complications from IV therapy. Collaboration with the provider is essential when patients are unable to take insufficient fluids on their own. Establishing a plan for both hot and cold liquid consumption, along with offering a variety of fluid options, can help avoid the need for IV feeding. Fluid balance mastery. Effective strategies for treating fluid imbalance in patients with volume excess. Patients with fluid volume excess may receive orders for fluid restriction, limiting intake over a 24-hour period. A scheduled fluid intake plan helps evenly space liquids, and sugarless hard candies and chewing gum can alleviate thirst if not prohibited. Diuretics may be prescribed, especially for those at risk of congestive heart failure or pulmonary edema, requiring careful monitoring of daily weight and electrolyte status. Precision in measurement. Key protocols for weighing patients to monitor fluid status and ensure timely reporting. Assigning daily weighing to certified nursing assistants, CNAs, or UAPs necessitates reminders to measure weight before breakfast, under similar clothing conditions, and after voiding. Consistent use of the same scale is crucial for reliable data. Any gain of 2 pounds or more over 2 days should be promptly reported. Navigating fluid challenges. Best practices for outpatient assessment and care in long-term facilities. Nurses in long-term care facilities face challenges in managing fluid balance in older adult patients, particularly those on multiple drugs affecting fluid and electrolyte status. Diuretics, in particular, can disrupt this balance. Vigilance for signs of hypokalemia is crucial, as potassium imbalances pose risks, especially for heart patients. Dehydration and hyponatremia from infection often lead to hospital admissions, requiring skilled nursing to ensure sufficient fluid intake without compromising nutritional needs. Home care nurses must collaborate with infusion company nurses for patients receiving IV fluids or TPN at home, providing clear instructions. Adjustments to sodium intake may be necessary for older adult patients with fluid volume excess from congestive heart failure, requiring individualized judgments by the nurse and provider.